Hi, my name is Josie Caves Sivaraman, and I'm very excited to be here today to share some of the results from my dissertation as an example of how the North Carolina Violent Death Reporting System data can be used for research purposes. I'm a graduate of UNC Epidemiology, where I worked closely with the Injury Prevention Research Center, which also works closely with the North Carolina Injury and Violence Prevention Branch, which houses NC-VDRS. So we've been very fortunate to have a lot of access to this data, and I've used it throughout my career. The title of my dissertation was The Association of Mental Health and Substance Use Disorders with Suicide in the Medicaid Population. When we think about risk factors for suicide, I focus specifically for aim 1 of my dissertation on mental health and substance use problems and lethal means. And then in aim 2 of my dissertation, I looked at more proximal life circumstances and stressors, which NC-VDRS is a great resource for. When we consider behavioral health associations with mental health, there's been numerous studies done on this topic, and a general understanding that there are very strong associations. So some of those are listed on the right side of this slide. The U.S. is generally underrepresented in these meta-analyses, and that's likely because U.S. data linkages are very challenging. There's privacy issues and lack of centralization of our data in this country. And that's important because suicide in the U.S. is subject to unique conditions that might impact the association between behavioral health disorders and suicide. And that brings us to lethal means. So firearms are used in about half of U.S. suicides, and the U.S. accounts for about 1/3 of the global firearm suicides, even though we only make up 1/20th of the population. Over half of men tend to use firearms for suicide, and among female decedents, it's still 1/3. And when we consider lethal means and behavioral health together, it's important to understand that the decision to take one's own life is often made impulsively. The median time from making the decision to attempting suicide is about 10 minutes, and 2/3 of people will not reattempt suicide if they survive the first attempt. So preventing that first attempt can really extend a person's lifespan. And that's why lethal means make a big difference. 3% of suicide attempts that use poisoning are lethal. 85% of suicide attempts that use a firearm are lethal. So putting these together, we see that impulsive suicide attempts are more likely to result in death if firearms are used. Or put another way, people who act impulsively are overrepresented in firearm suicides. And if that is the case, then behavioral health associations with firearm suicide may be weaker simply because the person was acting impulsively. They didn't necessarily go to see a healthcare professional. They instead made this impulsive suicide attempt. So this specific aim, my first specific aim in my dissertation, was to determine the association of medical diagnoses with the outcome of suicide among Medicaid-insured North Carolinians, and examine how this association varies by sex, race, and suicide method. We used a case control design with incidence density sampling based on index month of suicide. We restricted to members with 1 year of continuous coverage prior to the index month, and we sampled controls at a 100-to-1 ratio, requiring controls to be living and covered during the index month. Now to do this, we linked the NC-VDRS data to Medicaid claims. We took all suicides and deaths of undetermined intent that took place between January 1st, 2014 and December 31st, 2017, and linked those. We were able to do this by taking advantage of the death manner abstractor variable in NC-VDRS. One kind of neat thing about NC-VDRS is that there's actually 4 death manner variables, one from the death certificate, one from law enforcement, one from the medical examiner, and then the abstractor looks across all of those, and if there is disagreement in any of those sources, the abstractor can look at the most recent information and see which one best aligns with the NC-VDRS definitions for each of these different violent deaths. So that's one really great reason for linking using NC-VDRS versus using simply death certificates or some other individual source. Now, we linked those to Medicaid claims data, and we were able to do that because the UNC Shep Center has a program called the Carolina Cost and Quality Initiative, which is an agreement basically between the Department of Health Benefits and the Shep Center that students and researchers may use Medicaid data on a case-by-case basis. So that sort of is a framework that's already in place that we were able to take advantage of, even though this specific linkage had not ever been done before. So we filled out a DUA for NC-VDRS, we filled out a DUA for DHB, and then there were several rounds of revisions and several rounds of questioning that we went through, and eventually DHB agreed to do the linkage. They performed it so that on their own, so that I never had access to these identifiers, but they were transferred directly from DPH to DHB, and the data were linked based on exact matches of first and last name, sex, and date of birth. Once that was done, we had about 1,300 linked cases. We ended up excluding 670 of these, mostly because they were not insured for 12 continuous months prior to death. So we ended up with 691 cases. 57 of those were undetermined intent, and about a third of those 691 cases were firearm deaths. We linked those, or matched those, to nearly 69,000 controls. These are the exposures that we looked at, the diagnostic exposures. And for this aim, we stratified by sex. We matched based on total months of coverage in the past 3 years, and we adjusted for these variables. And these are the results among women. So on the left-hand side, you can see that we've divided the diagnoses into physical disorders, substance use disorders, and mental health disorders. And the individual diagnoses are there in the middle, and then their associations are in the graphic. So the association between the disorder and non-firearm suicide is in gold, and the disorder and firearm suicide is in green. And the takeaway point from this slide is that for women, those are pretty close. The green and the gold dots and bars are fairly similar across the board. Not a huge difference there. However, when we look at men, we do see that there is some difference, especially looking across substance use and mental health disorders. So for men, we're seeing much stronger relationships with non-firearm suicide than with firearm suicide. And this is important because men who use firearm make up the largest proportion of suicides, but their risk is the least diagnostically identifiable. So when we're looking at who to intervene on to prevent suicide, for men who use firearms, we can't reliably look just at diagnoses. So for aim 2 of this dissertation, we looked among Medicaid-insured North Carolina suicide decedents. We wanted to identify suicide typologies using diagnostic data and information on individuals' circumstances proximal to death, and explore how these differ by sex, race, and suicide method. So in order to do this, we took advantage of the really rich circumstance information that's available in NC-VDRS. I really can't overstate the value of this data. So for each death, or nearly every death, the law enforcement and medical examiner each submit a narrative detailing the circumstances around the death. And the NC-VDRS data abstractor goes through those narratives and looks for specific circumstances. And there's an entire list of circumstances. So they say, you know, is there evidence of an intimate partner problem? Yes or no. Is there evidence of a financial problem? Yes or no. And they go through and fill out all of these different circumstances. For this aim, we were interested in circumstances that we categorized into our own categories, which were stressful life events, suicidal behavior, and perceived behavioral health conditions. One thing that you have to take in mind for this is that the law enforcement and medical examiners are gathering this data usually through like interviews of friends and family members, or from suicide notes, or from witnesses. So depending on the reliability of the source of that data and what the source is willing to communicate to the police or the medical examiner, there may be various biases in these data, but they're still extremely valuable and the closest information that we have on a surveillance population level to what people are experiencing prior to suicide. So we wanted to take those three categories or those three domains and we wanted to compare them to a fourth category of diagnosed behavioral health conditions and see how everything sort of lined up. We used a latent class analysis, which is a method that uses observed variables to find groups or subtypes of cases which are observed or latent, unobserved or latent. And we use suicide decedents age 25 to 54 to do this analysis. These are the specific variables that we looked at within each of the categories. So within stressful life events, we were looking at death of a friend or family member, criminal or civil legal problems, intimate partner problems, etc. And then we also had that suicidal behavior category. And then we had perceived behavioral health. So this is what the proxy that friend or family member might report that they believe the person to be struggling with or believe them to have a diagnosis of. And we looked at all of those three categories against diagnosed behavioral health based on what we saw in the Medicaid data. So we came up with a two-class solution for both men and women, and I'll talk you through this. On the left-hand side of the screen, you're going to see stressful life events, suicidal behavior, perceived behavioral health, and diagnosed behavioral health categories. And then in the middle are all of those variables. And then for each of the classes, their associated probability with each of the variables is listed in the actual figure. So if we look at the very bottom here, we have encounter in past 90 days. The people that sorted into the black class here have a 93% probability of encounter in the past 90 days. And the people that sorted into the gray class have a 56% probability of an encounter in the past 90 days. So looking through these, you can see in the first three categories that people look pretty similar, actually. The gray and black lines are almost equal in most of these variables. But then they're very different when we look down here at the diagnosed behavioral health category. And from that, we got the names for these classes. So the class that's listed in black here, we call the greater diagnosed behavioral health conditions class. And that was made up of 45% of men. And then in the gray, we have the fewer diagnosed behavioral health conditions class, which was 55% of men. Women had a very similar class solution to men. However, more women sorted into the greater diagnosed behavioral health conditions class at 71%. We also looked at the racial and suicide method component distributions for these classes, and we found that patients of black race were much more likely to be in the fewer diagnosed behavioral health conditions class, and men who used firearms for suicide were also more likely to be in that fewer diagnosed behavioral health conditions class. So there's a couple of conclusions that we can come to from this aim, especially when we consider the findings of the first aim as well, which is, first of all, that there needs to be better suicide screening. I think this is pretty universally agreed upon, but there needs to be better suicide screening for people in the black population at risk of suicide. And then we may need to rethink how we screen for people at risk of firearm suicide, just because they appear to be less diagnostically identifiable, particularly in the male group when you look at this second aim. And then lastly, we may want to start thinking about how we can incorporate stressful life events, suicide behavior, other life circumstance evaluations into suicide screening, considering that people look so similar, decedents look so similar across those different categories and so different in the diagnosed behavioral health disorder category. So with that, I will wrap it up. Again, my name is Josie Caves Sivaraman. I appreciate you sitting through this presentation, and I will be happy to answer any questions